So this is not meant to be comprehensive of all things transplant, but really to give you guys a good idea of acute issues for transplant patients. You're going to be seeing them when you're on call and during your rotations, and want you to have some familiarity with issues that we deal with on a day-to-day basis. So we'll talk about arrhythmias in transplant, infection, rejection, and please interject and interrupt with any questions. We'll talk about allograft vasculopathy. We'll talk about primary graft dysfunction and other early post-op complications. I show this every year, and I'm not going to make Sal, I don't know if he's even on, read this, but the point is you guys are the first line of defense for these patients. And so not to dramatize it a little bit, but you guys are on call in the hospital, and their life and death sometimes, is in your hands. And so you guys are the night's watch for us and for the patients, and we want you guys to know that that's an important role, and but also know that you're not alone. You can that we're here, and patients that are post-transplant are a unique population, and if there's any issues and it's not, we want you to call any patient with first year post-transplant, call us with a headache. I mean, the simplest thing is just call us. If they're long-standing patients, you'll get your field for it if they're coming in with a UTI versus coming in with vague symptoms that might be infection or might be rejection. But you'll get in much more trouble for not calling us than for calling us, I promise. At least I'm speaking for the heart failure side. So it's important to know that there's two techniques that are done for transplant, for heart transplants. This is the biatrial technique. So focusing on the right atrium, you can see that they are anastomosing both the donor and recipient atria. So the recipient will have part of his own native remnants of his right atrium along with the new donor right atrium. So it's important to know because that does have consequences that we'll talk about. And it's a little bit quicker ischemic time to do biatrial, but it does have more potential damage to the SA node due to the location of anastomosis, and thus more potential bradyarrhythmias. This is the bicable technique, so you can see the anastomoses are at both the superior and the inferior vena cava. And the left atrium is, they take a small cuff of the left atrium for the pulmonary vein ease of implantation. So this, you can see, leaves the donor right atrium, it leaves the recipient right atrium out of it, so that all the atrium on the right side should belong to from the donor. Does that make sense? So there's a video here. If this is saved, you can click on YouTube and watch a transplant. But I would encourage you all, when you're on your heart failure rotation, to go out and see a transplant, both when we're going out to get the heart and when we're implanting it. I think it's really important to understand what happens in the operating room, and both for transplant and LVAD, I would encourage you. So if you're on the rotation and there's an offer, come to whoever you're rounding with, come to me, say, hey, I want to go out and fly out. Hopefully, I don't know the policy now with COVID, but hopefully you guys should be able to go out and see the transplant. So if you're not going into heart failure transplant, you should see at least one. If you're going into transplant, you should see a few. So about 2/3 of the transplants in the U.S. are done by the bicable technique, and 1/3 are biatrial. We used to do biatrial until about 5 or 6 years ago. We changed to bicable. So the biatrial is simpler and it's a little bit decreased ischemic time. I still don't understand exactly why that is. Bicable seems more straightforward to me. The disadvantages include a higher risk of sinoatrial node damage, atrial tachyarrhythmias, as well as bradyarrhythmias. About 5% of patients that have a biatrial technique will need a permanent pacemaker prior to discharge, compared to 2% of patients with a bicable technique. And we certainly saw a decrease in our permanent pacemaker needs after we switched to bicable. There have been a few meta-analyses that have looked at differences in survival, et cetera, between the two techniques. There was one study that was a UNOS database, retrospective study that did find a small but significant increase in long-term survival between the atrial and cable groups, with the benefit towards the bicable group survival. That said, there's another study showing that if you need a pacemaker, patients that get a pacemaker and need a pacemaker may have a survival advantage. So the possibility that there's some occult arrhythmias that are not being picked up by our monitoring technique. So bradycardia is something that we need to be attuned to post-transplant. So early post-transplant, post-operatively, we like, if the heart rate's less than 90, all our patients will come out of the OR. What is it? Are they saying yes? Okay, perfect. So all the patients that are coming out of the OR will have temporary epicardial pacing, should be both atrial and ventricular. And so if they're still, we will assess them daily by turning down the pacemaker's rate. And if they're having persistent bradycardia, most of these patients are going to be on inotropes for several days post-transplant anyways, but we might augment those and or start oral beta agonists in the form of terbutaline. If it's persistent, then we'll consider the pacemaker prior to discharge. If it's sustained and symptomatic and it's more than a week post-implant, we're going to evaluate them for rejection anyways and see if that's a factor. The different, it can be due to a lot of things. It can be due to the technique, and it could be due to ischemic time. It could be due to inflammation. It could be due to rejection. But overlying is the fact that you have vagal denervation in these patients. So in terms of late onset bradycardia, if they have hemodynamic compromise or LV dysfunction, then you're going to assess them for rejection or for coronary allograft vasculopathy, which is new coronary disease in the donor arteries. If not, then you'll make sure there's no drug effect, and if they're still bradycardic, then you would have a little threshold to put in a permanent pacemaker. So the heart is denervated, so you have loss of both the afferent and efferent pathways. You can have sympathetic and parasympathetic reinnervation that can occur with time. That's much more likely to be sympathetic over time. It's much more common than parasympathetic. The degree of reinnervation is incomplete, not uniform. It's not predictable, and it varies quite a bit. So most patients will have a resting tachycardia in the 90s or 110s. That's what we want. If their resting heart rate is below 80, especially if they're within their first year of transplant, that is a concern to us. And if that's persistent, they'll have a very low threshold to put in the pacemaker if they're on terbutaline, et cetera. Angina is uncommon due to the denervated heart, and patients are more reliant on circulating levels of epinephrine and norepinephrine, and there's a loss of feedback regulation. So when you're thinking about some medications that rely on the vagus node or that rely on the vagus pathway, you think of atropine, one, so normally that'll increase the heart rate. It usually will not have an effect on the transplanted heart. Adenosine is more controversial. Traditionally, because it has receptors in the SA node and AV node, you would be perhaps have an exaggerated effect to adenosine. And so far, because of that, we don't typically use adenosine, although there is more recent data that's looked at patients going for stress tests, for example. I think Dr. Amala was author on one of these papers that showed that you can give adenosine safely in patients for stress testing. Another study took 80 patients in the cath lab and gave them a temporary pacer and gave them all adenosine up to 12 milligrams, and none of them needed to be ventricularly paced. They have a little bit longer pauses, perhaps, and more AV block when you have adenosine, but overall, it's not as worrisome as one would think, but I would still be very cautious. If you're using that in a transplant patient, I would definitely have temporary pacing pads available. And beta agonists and beta blockers, due to receptor density changes, may also have an exaggerated effect, so beware of that. And then digoxin also, because it relies on the vagus nerve system, also typically is not effective in patients that have transplant. So we'll talk a little bit about arrhythmias before going on to other things, of other types of arrhythmias other than bradycardia. So atrial flutter is more common than AFib, especially beyond the perioperative period. It's the most common arrhythmia associated with rejection, and it's associated with LV dysfunction and an earlier mortality. So if you see a flutter, you would have a very low threshold to biopsy these patients. Certainly an urgent echo would be warranted. Non-sustained VT can also be relatively common in the early post-op period. There's been, yeah, go ahead.
But is it possible that if you look at the echo and the echo shows that how sensitive the echo in detecting like graft failure? But it's been rejection, but the echo wouldn't see fine.
So the echo, I mean, if there's obvious systolic dysfunction, then that's obvious. But you can have rejection with normal graft function. So I would not, if you're suspicious for rejection, a normal echo shouldn't drive you away from doing the biopsy. So if you have non-sustained VT, it could be pretty common, and it's variably associated with rejection or graft failure. Sustained, symptomatic non-sustained VT that's late after transplant, that can often be associated with severe allograft vasculopathy or blockages in the new arteries. Sustained VT is uncommon after transplant. We would definitely consider a coronary angiogram and a coronary biopsy in those patients. So sudden cardiac death is something that can occur in these patients. Of those who die from cardiac causes, about 25% of them die from sudden cardiac death. And most of those causes are due to rejection, ischemia, or severe allograft dysfunction. Many of these patients have no anatomic abnormality and have death from primary arrhythmias, asystole being the most common. So in terms of early postoperative morbidity and mortality, RV failure is something that should be on your radar. This is most commonly due to pre-existing pulmonary hypertension. This is why we fuss so much about transpulmonary gradient prior to the transplantation. So if someone has RV failure, inotropes, nitric, we have a low threshold to use inhaled nitric oxide, PDE5 inhibitors, et cetera. And then some patients come out systemically vasodilated. Often we assume sepsis and treat them empirically as if they have sepsis, but this can also be just sears due to the cytokines from the cardiopulmonary bypass, et cetera. So for these patients, antibiotics, vasopressors, tuned towards their hemodynamics, and then if refractory, we might use methylene blue as well. And now we also have the new drug, the someone help me out. Angiotensin.
Angiopressor.
Yes, thank you. So, and then hyperacute, acute rejection, primary graft failure, which we'll talk about in a moment, that's not immune mediated, bleeding, and then bradycardia, which we've already spoken about.
The bradycardia is mostly sinus, or just blocks, or? So
it can be. I mean, it can be all of the above. I mean, it's typically it's usually sinus, but these patients can have asystole as well. But usually it's sinus or junctional. So in terms of graft failure, graft failure is the most common cause of short-term mortality after heart transplant. Early graft failure is defined as within the first 30 days having a composite of death or retransplant associated with graft failure. It can be left ventricular dysfunction, RV, or both. The incidence is around 3.8% of early graft failure and a high cause of mortality and retransplantation. There's different classifications which we'll look at in a moment. There's primary, where there's no obvious cause. Secondary, where it can be sepsis, infection, or RV failure in particular. And the risk factors for primary graft dysfunction, depending on the study, but these are some of the common risk factors. Prolonged ischemic time, especially the warm ischemic time. So after it's off ice and they're putting the heart in. The donor cause of death, especially if it's brain hemorrhage. Donor LVH and LVF, if they're borderline LV function. Increasing donor age, gender mismatch, size mismatch. And then in terms of the recipient side, preoperative use of ECMO, RVAD, diabetes, or pulmonary hypertension. So these are the different criteria, the classification for primary graft dysfunction. We don't have to go through them in detail, but mild would be, EF less than 40, both, high wedge, low cardiac output. Moderate would have, the need for high dose inotropes or a balloon pump, and then severe is, need for unilateral or biventricular support. And then there's an RV PGD as well, which would have to have normal wedge and a high RA pressure and a low cardiac index, TPG less than 15, and or need for an RVAD. So the management of primary graft dysfunction is largely supportive. It generally involves a combination of inotropes and mechanical support. First line, depending on how bad it is, might be a balloon pump if it's just mild, but if it's more than that, then typically we would support the heart with biventricular support in the form of ECMO. And oftentimes by doing that and resting the heart, so to speak, you're able to regain graft function. So immunosuppression is post-transplant is really a balancing act between infection and rejection. So MJ, patients die more commonly from infection or rejection in the first year? Infection, good. Yeah, you didn't take the bait. So yes. So we worry a lot about rejection, and for good reason, but infection is still the most common cause of death in the first year. So if you look at this graph, this is the UNOS outcomes. So in the first 30 days, non-specific graft failure in the green is the most common cause, but after 30 days and up until a year, infection is the #1 cause of death. Long-term, and you can see rejection in the, I guess you would call that beige, maybe. You see it down, it's the third from the top there, third from the bottom in the early, and if you track that on, it really is not one of the top 3 causes of death in these patients. And if you look beyond 5 to 10 years, it's one of the least likely causes of death. It doesn't mean we should ignore it. I mean, it's important. It does have repercussions and increases your risk for coronary allograft vasculopathy and other issues, but just know that infection is a more common cause of death. And then long term, beyond the 5 to 10 year period, cancer is the #1 cause of death. So in terms of rejection, about 20 to 40% of patients will have rejection in the first year after transplant. The more episodes and the higher severity does correlate with mortality and CAV. It can be asymptomatic, it can be symptomatic, it can have graft dysfunction or not. Symptoms can often be vague. You have to have a very low index of suspicion. We've had patients just say they feel a little fatigued or something's not right, or maybe just have a mild fever. It can be very vague to very dramatic presentations. But even the vague symptoms might correlate with dramatic drop in ejection fraction and terrible hemodynamics. So you have to have a decent index of suspicion for it. If you have an index of suspicion that warrants it, then you should do an urgent biopsy. There's 3 different types of rejection. It could be hyperacute, acute, or chronic. Hyperacute, hopefully you'll never see a case due to the current techniques of detecting antibodies and cross-match. Hopefully you'll never see a case of this. It's very rare, but if you do see it, it should be heart failure within minutes to hours of the transplant, often when they're still in the OR, causing acute graft failure. and that's certainly an emergency.
Does that present like hemodynamic stability? Is that how you identify it?
Yes, and loss of function. So in terms of the nomenclature for cellular rejection, we'll have a dedicated lecture to cellular and antibody-mediated rejection down the road. So I'll just give you guys a little bit of it, just to get understanding of it. So this is the current nomenclature. So 0 is having no rejection at all. 1R is mild rejection. This is having one focus of myocyte damage and lymphocytic infiltration. This is considered acceptable level of rejection. We don't treat that. We're very happy if it's 1R. 2R is having 2 or more foci of infiltrate associated with myocyte damage. 3R is severe. There's diffuse lymphocytic infiltrate, multifocal myocyte damage, and edema, hemorrhage, vasculitis, etc. So this is an example of 1R. You can see in the top left, I don't know if my pointer shows there, but you can see just some mild infiltrate here, that in higher power. So you just see it in one part of the biopsy here. This is, so in terms of the nomenclature for antibody-mediated rejection, it's a little bit more complicated. This is an older definition. It's really just kind of present or absent. And absent meaning that there's no evidence on the biopsy. So on the biopsy, you'll look for, typically we look for immunofluorescence of C4D evidence. So having, the complement pathway byproduct. And then you look at histological findings of capillary endothelial swelling, macrophage activation, etc. If you have AMR, either by biopsy, or you can have AMR by the presence of donor-specific antibodies, but there's a lot of questions on what that means in the absence of symptoms or abnormal graft function. So there's been an updated pathological diagnosis for AMR. Typically, we don't really use that one here, but it's based on histological or immunopathological criteria. So we do use aspects of this in terms of, we use the C4D % staining and CD68, and we look at the histological characteristics. We just don't, typically our pathologists don't grade it according to this AMR 0, 1, 2, 3. Issues with this are, it doesn't, and it's just strictly a pathological diagnosis. It doesn't take into account the presence of having donor-specific antibodies. It doesn't take into account graft function, and even the criteria of the cutoff for C4D, which we commonly use, 50% or more staining in the biopsy. That's just been defined by expert consensus and is not a established criteria by evidence. So if you have symptomatic cellular rejection, obviously these are the class 1 indications. You should do a biopsy if there's suspicion, and if they have symptomatic rejection, definitely need to be hospitalized. High-dose steroids are the first-line therapy, respective of the grade, and then cytolytic immunosuppressive therapy with anti-thymocyte antibodies, so like thymoglobulin, should be given to patients in addition to steroids if there's any hemodynamic compromise, and often we'll give if there's graft dysfunction. We will use whatever it takes to maintain adequate perfusion, whether that's inotropes or mechanical support in these patients. And this is a very reversible cause of heart failure. So we have a low threshold to throw everything in the kitchen sink at these guys because they often will recover with time and treatment.
Does pre-treatment with steroids decrease your sensitivity for biopsy?
Yeah, it's one dose, like 6, if you give a dose the night before we get a biopsy, it's unlikely to have a major impact. But yeah, if you treat for 2 or 3 days, a week, it comes out on Friday, and you don't want to get a biopsy, and you wait till Monday after getting 3 grams of steroids, that might decrease your sensitivity of a biopsy. So we always give antibacterial prophylaxis, antifungal prophylaxis when we're giving high-dose steroids or cytolytic therapy, and we adjust immunosuppression accordingly, and then follow-up biopsies, etc. If there's asymptomatic rejection, if it's severe grade 3, we always treat grade 3 aggressively, no matter asymptomatic or symptomatic. If it's 2R, which is moderate rejection, we will treat, depending on symptoms, hemodynamics, and graft function, either with an oral dose at home. So someone that comes into the hospital for just a biopsy, they're feeling great, their hemodynamics are perfect, echo's perfect, and they come back with a 2R, we'll probably treat with 100 of prednisone for several days. Whereas someone who has a wedge of 20 and an EF of 45%, they're going to be admitted and put on IV pulse steroids, a gram, for 3 days, and watch closely in-house. And then follow-up biopsies, well, it's not really an emergency. So in terms of hyperacute, again, hopefully you guys will never see this, but while they're still in the operating room, typically these guys are given high-dose steroids, plasmapheresis, IVIG, thymoglobulin, these guys, and mechanical support, and usually would need urgent retransplant. But you guys won't be managing those, hopefully ever, and especially not without us. But if you do, for whatever reason, you should just be vaguely aware of it. So for AMR, the treatment's a little different. For AMR, it's still, especially if there's graft dysfunction, steroids and thymoglobulin are still high up in the hierarchy of patients. So those are non-specific therapies that can decrease both T cell and B cell response. So those are useful, especially in mixed rejection as well, those that have both humoral and cellular features. In addition to that, we often do plasmapheresis and other things to remove circulating antibodies like IVIG, et cetera. So, and again, for those patients, we support them however they need to be supported. And this is just a nice graphic showing for AMR the pathway. You can see activation of CD4 cells, and then the macrophage activation and B cell, plasma cell antibody activation, and different therapies that are directed at different stages. So IVIG and steroids are sort of non-specific and can help at any stage of this, whereas, as well as thymo, whereas rituximab is more B cell mediated, bortezomib is plasma cell mediated, and you can also work at removing antibodies that are circulating by plasma exchange or immunoabsorption. And then there's also new therapies developed at complement activation. So, and going back to infection, just as we said before, more patients will die from infection than rejection. Sepsis does cause about 20% of all deaths in the first year, and patients may or may not have a fever or leukocytosis. So just be aware of that these are, like older patients that are immunocompromised, and they may not mount those reactions. In terms of the type of infections you might see, so the first month you see typical conventional nosocomial infections. Up until the first 6 months, you'll see common opportunistic infections that you might be familiar with by treating patients with HIV, including CMV and PCP, Cryptococcus, toxoplasmosis, etc. We have had a couple patients that have died of toxoplasmosis within the first year of transplant. So so it's really important to know when you're treating the patient, what is the donor antibodies and what are the recipient antibodies. If you have a mismatch, so the highest risk would be a patient that has donor for toxa, the donor positive, negative? Donor positive and recipient negative, right? So that would be the highest risk patient. And if you don't treat them, particularly with Bactrim, prophylactically, the risk of getting toxo in your first year is how high? Anyway, throw out a number.
20%.
Over, under, 21, 19? It's like 50 to 80%. It's very high, and it can be deadly. So we sometimes Bactrim gets stopped for maybe a sulfa allergy or for increased potassium, or maybe they're worried about the creatinine. But you should not stop Bactrim if they have a toxo mismatch, unless you're 100% sure that's causing the issue and you can't treat it another way, with potassium binding agent. Or,
Can you do a protocol?
you can do a tovaclone, but it's not as good for toxo. So, and then after the first 6 months, it's important to know that even though they're at risk for opportunistic infections, and CMV is still a persistent risk, but outside of CMV and someone that's not a toxo mismatch, the most common infections will be community-acquired infections after that period. So CMV is something that we check for frequently. Patients, obviously it's a latent infection, and it has really a host of effects. Commonly, we see GI manifestations, but it can involve really any organ, often with non-specific, just flu-like symptoms. And we have lost a couple patients to CMV infections that were resistant to therapy. So it's something that we do watch for. It is something when someone's coming in for vague fever, you have to think, is it rejection? Is it CMV? Is it other infections? It has to be on your radar. And then we do check it frequently so you can see, where we are in terms of the last time it's been checked, et cetera. So it should be, we do give prophylaxis to patients, so that just like toxo, the highest risk is the patient that is recipient negative but donor positive. So those we treat a little more aggressively, but all these guys should be on valsite. Unless you're negative, then we put them on acyclovir just to kind of make us feel better. But otherwise, they should be on valsite if they have any mismatch at all, or positive, or if any one of them is positive. And we'll skip that. And then looking at long-term morbidity, almost all these patients will ubiquitously have hypertension. Renal dysfunction is common in these patients due to prograft and cardiorenal, and et cetera. Hyperlipidemia, diabetes is common. And then the last thing to discuss is allograft vasculopathy. So this is new disease in the new heart. And the clinical presentation is often asymptomatic. Classic angina is very rare due to denervation. You may see EKG changes or syncope or sudden death or heart failure. And these are the known risk factors for developing CAV. So some are the traditional risk factors, but a lot of these are donor specific in terms of donor age and donor hypertension. The more HLA mismatches, the more CMV infection you have, and the more episodes of rejection. So it's really important that we try to minimize rejection and CMV infection in these patients long term. So this is not your typical coronary disease. So typical coronary disease, as you know, is as you can look at the top panel of the picture, you see a focal proximal atherosclerosis. This is typically concentric, as you see with the intimal thickening here in this picture. It's typically diffuse. You may not appreciate it on angiography because you may not see a focal blockage. You may just see a very distal tapering of the vessel. So it can be very deceptive. That's why some centers use IVUS routinely. We don't typically, but it's important to catch it early so you can try to use different therapies to ameliorate it. And we can skip over that. And so allograft vasculopathy, it's really usually a later phenomenon. It's more common as the years go by. So whereas it's in the first year, only about 8% of patients will have it. By 5 years, about 32% of patients have it. Because of that, we have evidence to show that butane echo can safely, because of the low prevalence, largely, can safely evaluate patients for having CAV in the first 5 years. But once they hit 5 years, we're going towards angiography in everybody. So a lot of these patients don't seek medical attention. That's why we do a just routine annual angiogram after year 5. And then just one thing I just want to keep highlighting is, we have no shortage of options to add hemodynamic support to patients. So if they're crashing from rejection, we have all the tools we need to support these patients. We've had patients with 20% EF, cardiac index less than 1, that you give a few days of thymo to, put them on ECMO. A week later, they're able to take ECMO out. Their heart functions back to normal. So it's really important that we intervene, have a low index of suspicion on these patients, intervene early and aggressively with whatever tools they need. Obviously, we don't want to put an ECMO on everyone. We tailor it towards their hemodynamics. And if we can get away with a balloon pump and that's all they need, then that's great because it's less side effects, but a low threshold to augment after that. So I know that was kind of a whirlwind towards kind of emergencies that you might see in the first year, but definitely want to hear questions. I don't know if my colleagues are on, if there's anything you guys want to add, please feel free to do so.
So for the CAV, you said after 5 years if you do angiography, but since you also mentioned that the lesions are diffuse, I mean, then you can't really read them so well.
So Michelle is asking why you can't do, why do angiography if you're not able to intervene or appreciate all the lesions. So there are times when they are focal and they're not always diffuse. And we do, if we have a significant lesion by percent stenosis or by FFR, we will stent it. Now the data, there's no data, although there's not great data on stenting asymptomatic lesions in the general population. The transplant numbers are much smaller, so we don't have good data on whether that's helpful or not. But we'd rather fix a severe lesion than leave it alone for what it's worth. And the other thing is, if you notice that they have allograft vasculopathy, it's an opportunity to consider switching their immunosuppression. So mTOR inhibitors, for example, like Rapamune or everolimus, they do decrease the intimal proliferation and can decrease the CAV. So if we find CAV, especially if we find it early, we will try to switch them to an mTOR inhibitor. We'll definitely try to augment anti-lipid therapy. All these patients should be on a statin post-transplant anyways, but we might have opportunities to increase therapy. And then there is a rare patient that might benefit from a bypass. That has been shown in very small, handful of series that it might have a benefit. Of course, it's not randomized controlled. But ultimately, if you have severe CAV, the only real thing that's proven to be of benefit is retransplant. So that's why we might do it.
You said that there's a deteriorating response for beta blockers. So you said that almost all of them have hypertension. So you don't use beta blockers?
We don't use beta blockers in the first year, except for rare circumstances, because we worry about, especially if they don't have a pacemaker, causing radiated arrhythmias. We will, over time, consider it in patients that are several years out. If they don't have, a lot of these guys have, CKD that's advanced, so we're a little bit more limited. So we might use beta blockers, but we'll do it cautiously, start low, and and monitor them closely with it.
What would you like to keep the heart rate at?
Yeah, so the heart rate early on, we wanted to be certainly above 80, but ideally above 90, when they're in their index admission in the first few months post-transplant. We, in the long term, was certainly, for someone that's multiple years out, if they're going under 80 and they've been like that for a while, they're 70 plus, but 70, we might be okay with that. But we don't know. There's some data that shows maybe they might benefit from having a lower heart rate. I mean, relative lower, like 90 versus 110 over time. But we definitely worry about bradyarrhythmias the most, because some of these patients might have silent asystole or severe bradyarrhythmias that can kill them. So ideally, the first year, definitely over 80, if not over 90. After that, definitely over 80, and 70 to 80 depends on how far out they are and if it's acute or chronic.
But if somebody comes in with like a flutter with RVR, let's say within that first year, do you still recommend rate? I mean, you don't do rate control. Are you using rhythm control?
Yeah, so we might. So that's a challenge. First of all, if they come with a flutter, that's not common, and so we're gonna really try to figure out what's going on in terms of in terms of whether they're having rejection. But yeah, if they're in A flutter and their heart rate's very poorly controlled, our hands might be tied in terms of using beta blockers or even amiodarone. It's not ideal, but at that point we might have to use a little bit.
Along with that, is it pretty low threshold to just give the IV steroids? Like,
yes, very low threshold. So that's why it's important to call us in the middle of the night. The question was, is there a low threshold to use IV steroids? And so yeah, if there's a patient that comes in and has symptoms that are worrisome for rejection, it's unless there's some signs of sepsis, which sometimes can be hard to differentiate, and it's typically we want you guys to call us, and then typically it's shoot first and ask questions later. And an echo in the middle of the night, despite what Dr. Nago might say.
In your experience, if someone's like 8 or 9 years post-transplant and they maybe skip a few doses for a few days of their immunosuppressive medication, would you expect, and then they present, they're just doing fatigue, would you expect even missing just a few doses for them to reject at that point?
Yeah. So it depends. We have seen it. And some patients metabolize differently and are higher risk. Certainly, younger patients are much more likely to have rejection, especially if missing a couple doses or not. Women are more likely just get more HLA mismatches. African Americans have been shown to be more likely to have rejection. So if you have a young woman, definitely, they can. I've seen even with just not missing doses, but program metabolism can vary, and so you might not be therapeutic at the same dose, and we don't check for a few weeks because you're 8-9 months out, and then your level drops, to below our goal, or not detectable, and you can have severe rejection. And then we have patients that are just survivors that somehow ran out of their meds for 2 weeks, and we biopsy them and they're fine. So.
Are markers like the BNP and troponins, do you interpret them the same in like heart failure in transplant patients as you would for regular?
No, because there's not a lot of good data. I mean, there's some programs that use BNP, and there's some data to show that they might correlate with rejection, but at what level and what does the BNP mean in the transplant patient? Still not clear. Troponin, I would be concerned about. I mean, that's a marker for myocardial necrosis, and unless we have another explanation, I would assume that that's rejection, or I would at least evaluate for rejection. But we don't use them routinely for that purpose. We do have some other tools for rejection. So we have an OWL map, which is using the peripheral blood monocyte gene expression. There's a score that can predict cellular rejection. There's now an AlloSure, which uses circulating free DNA that can look for AMR. So those we're using for research studies and somewhat clinical as well, especially for the OWL map, which has been out for several years. So there are some non-invasive ways to evaluate for rejection.
If the patients are having arrhythmias, do they perceive palpitations, or is it?
Do they receive what?
Like palpitations, do they feel that their heart is fluttering or anything like that, but they don't feel?
Yeah, I mean, often they may or may not. I mean, it's just they sometimes will not feel it, but typically if they're going very fast, they might feel the hemodynamics and the consequences of that. But yeah, they can be asymptomatic.
Yeah, Dr. Trachtenberg, actually I was going to ask, patients that have primary graft dysfunction, do we ever check non-HLA antibodies to see if it's related to that, or we do kind of just? The problem with
non-HLA, so yeah, we didn't talk about that. So you can have antibodies that are not HLA, not against HLA. So the problem with that is one that it takes us, those are send out labs to California, and that takes at least 2-3 weeks to come back. So it's not going to really help you, other than if you want to make a diagnosis, autopsy or post-op. So we send it, but we don't really act upon it, and it's not a common cause of hyperacute rejection or primary graft failure. It's more of a commonly delayed cause, but there's a lot we still don't know about it. All right, so I'm going to hang up on the Zoom component unless there's anyone else that has a comment or a question. All right, thanks, guys.